Hey everybody, it's Ginny, VS Ginny, and this is my 16-week post-op vertical sleeve gastrectomy update and a very special FAQ video. This video, I'm just going to give a brief update on how I'm doing, um, and then I'm going to talk about the top 10 questions that pre-op VSG people have, or people considering the VSG. So I've obviously spent quite a bit of time researching this surgery before I decided to have it, and I've done quite a bit of reading on it since then. And over and over in weight loss surgery groups, you get the same questions. So um, obviously, I am not a doctor, but I'm going to give you the information that I've learned about basically. Um, all these different questions that people have. So anyway, I'll get to that in just a minute. As I said, this is my week 16 update. It's Friday, July 17th, 2015. Last Friday, I was 418.2 pounds, or 189.7 kilos, and today I'm 414.8 pounds, or 188.2 kilos. So a loss of 3.4 pounds, or 1.5 kilos. Pretty cool. To give you a recap, in case you don't usually watch my videos, my high weight was actually 600 pounds, or 272.1 kilos, back in January of 2014. The date of surgery, the 28th of March 2015, I was 488.2 pounds, or 221.4 kilos. So the total weight I've lost so far is 185.2 pounds, or 84 kilos, and that's since January of 2014. And total weight I've lost since my sleeve surgery, 73.4 pounds, or 33.3 kilos. So pretty awesome. Okay. So, first, let me do my shout outs before I forget. I want to give a shout out to Monica Sleeve McQueen, Jennifer Bleacher, VSG Tony Michigan, Lorraine. I should have looked up people's names. I only know them on Facebook. And I feel like I'm leaving someone out. Anyway, a bunch of really awesome WLS YouTube folks went and did the color run. Some of them together, Jennifer by herself last week, and for some of them it was their first 5K, and I think it's completely awesome that that you guys did that. It looks like a ton of fun. I loved the tutus, and I loved all the photos, and I loved watching the web show this week, the Naked Truth WLS web show. With you guys host, well, with Lizzie, finding Elizabeth hosting, and you guys as guests. It was just a ton of fun to watch. So thanks for that. So now I'm going to go ahead and talk about the top 10 questions that pre-ops or people considering VSG have about the sleeve. And by the way, sleeve, vertical sleeve gastrectomy, VSG, they're all interchangeable. It all means the same surgery. So the number one question is this sleeve right for me? Is this surgery right for me? Is this something I should do? Nobody can really answer that for you, but you need to be your own best advocate. And the best way that you can decide is to actually go out and do the research on your own. Use Google. Look for reputable sources. You're looking for the National Institute of Health, the American Society for Metabolic and Bariatric Surgery, basically reputable big medical websites or medical journals, and basically look at compare the average excess weight loss percentage for each of the surgeries, compare the revision and reoperation rates, because that's going to tell you which surgeries have to be undone later because there's been some kind of problem, or added to later because they haven't been effective enough. And also the excess weight loss percentage over time. Like, you really want to look at as far out as you can, because you don't want a surgery that's going to work for you short term and not work for you long term. And to be honest with you, that was my biggest concern about the sleeve for myself, is that I would lose a lot of weight and then end up regaining it, because that does sometimes happen with people having the sleeve. So like I said, you need to go out there and research this to death. And once you have figured out which surgery is right for you, then you do some more Googling. You look in WLS forums and basically anywhere that you can get info from other WLS patients on which surgeons are the best for your surgery. And I don't even necessarily mean best in your area. If it's something like the sleeve, there's probably like a lot of surgeons who are capable in your area. It's not a really difficult surgery unless you're being revised from something else, then it can be. So for the sleeve, you probably don't need the best of the best. But if you're going to have a more technically difficult surgery, like the duodenal switch, or something along those lines, you may want to spend some more time researching surgeons. You want to make sure that when you go in there and you're on the operating table and they are about to put you under, that you feel comfortable knowing that the person who's about to cut your body open knows what he's doing, or she. I think that's very critical. So, okay, the second question, and this is actually something that was kind of a blow up on a Facebook group this week. It's interesting. Facebook groups can be really good support, and I'm absolutely an advocate of them for that reason. But you have to understand that most people in Facebook groups don't, like, they basically take what their doctor says as gospel, what their surgeon says as gospel. And while I fully endorse listening to your surgeon, again, I'm not a doctor. Many surgeons out there lump the RNY, which is another word for gastric bypass, they lump that together with the sleeve, together with the lap band, and give patients the same information for all three, on diet, on after effects of the surgery, on medications you should avoid post-surgery, things like that. And all three surgeries are pretty different. So you need different information. And the duodenal switch that I mentioned earlier is even different from those, like very different. Oh, and also vitamin needs are different between all those surgeries. So this is why I'm saying research your own surgeries. Have a good handle on which surgery is right for you and everything that you need to do after that surgery, because you may not get the best post-op care information from your surgeon's office. Their job is to do a really great job cutting you open, operating on you, making sure everything works physiologically afterwards. But there's nothing that really holds surgeons accountable for giving correct information post-op on any of those things that I mentioned. So it's your responsibility as the patient to really learn all this stuff on your own and make sure that you're comfortable with it. So one of those things, the second thing that I was going to talk about that led to the blow up in the Facebook group was a discussion about non-steroidal anti-inflammatory drugs, also called NSAIDs. It is very true that you cannot take NSAIDs after RNY, gastric bypass. You can't. People who've had gastric bypass are more prone to a specific type of ulcer. I'm blanking on what it's called. I just looked it up last night, but there's a specific type of ulcer that you're more likely to get after RNY, and the issue with it is that RNY patients have a blind stomach, or in other words, a stomach that can't be scoped very easily, and maybe not at all. I can't remember for sure, but anyway, they can't get in there and see what is wrong with it or fix it easily. Basically, if they want to fix it, it requires, it can require opening you up again, and you can also have ulcers without really having these symptoms. That that actually happened to someone I knew. She actually had RNY, and she ended up bleeding out from an ulcer and passing away, which was incredibly sad. And one of the reasons that I would never consider the gastric bypass for me personally. Um, Even though I think for some people it's, it can absolutely be the right op for you, it just wasn't for me. Um, so anyway, so because of that risk, gastric bypass patients can't take NSAIDs. Um, but sleeve patients, we don't have the same predilection to ulcers that gastric bypass patients have because of our different anatomy. And if there was a problem, they can actually stick a scope in us and check things out, because we have a smaller stomach, but it's a fully intact, normally functioning stomach. So there's no problem with going in and seeing the issue. So some surgeons will still say, just don't take NSAIDs regardless of your surgery. Just stay away from them. But if you've had the sleeve, or if you are considering the sleeve and you have to take NSAIDs regularly, talk to your doctor, because it may not be precluded. I know that for me personally, I do take NSAIDs regularly. I haven't had any problems, and I don't anticipate having any problems. So don't discount having bariatric surgery altogether if you think you are going to have to take NSAIDs for the rest of your life. Just look at types of surgeries that aren't gastric bypass, and again, talk to your surgeon. Okay, so question number 3: how much can you eat post-op? That depends on the size of bougie that your surgeon uses. A bougie is a measuring tool they basically put in there to help them measure out how big to make your stomach. And most sleeves are made so that once you are mostly healed and swelling has gone down, your stomach, which takes a couple months, your stomach will hold approximately a half a cup of food. So that's pretty typical. But like I said, it does take a couple months for the swelling to go down, so you won't be able to even eat that much before that. It takes a while to actually get there. And also how much you can drink at a time post-op. I haven't had any problems with fluids, but some people do. Some people have to take them really slowly. I drink them relatively slowly, but not always, and I haven't had issues with that. Even immediately post-op, I was able to get in my fluids. I was very lucky. Some people have to start out with very small amounts, but and I try to drink about 80 ounces or 2.4 liters every day. Some people drink more. I might try to take that up at some point, but for right now, that's working for me. Dumping. Okay, not a pretty topic. What about dumping? So gastric bypass, let me start by telling you what dumping is in case you don't know. Dumping is when food moves too quickly from your stomach to your small intestine. And what happens when you have a dumping episode is things like vomiting, nausea, shaking, dizziness, diarrhea, vomiting, yeah, all kinds of awful things that you don't want to go through. And sometimes I see people in the sleeve community talking about dumping as a sleever. You really don't dump as a sleever. I mean, it's very unlikely. What causes dumping in RNY patients is that as part of the RNY, the pyloric valve gets removed, and that's the valve that sits between your stomach and your small intestine, and gradually opens up to let food through. It lets food through very slowly, very gradually, and so when that is removed, then you have dumping. With sleevers, the stomach is made smaller, but the pylorus is left intact, so you don't get dumping. That's not to say that you're never going to eat something that doesn't agree with you and have an episode of diarrhea or vomiting or whatever. But it's technically not really dumping. Some people can call it that, but technically it's not really what it is. And we definitely don't have episodes like that every single time we eat something that's high in sugar or high in fat, or whatever, like gastric bypass patients sometimes do. I know that not every gastric bypass patient experiences that, but it's definitely not to the same extent. So that was that was another reason that some people do like that effect. They feel that it keeps them on track and not eating sugary foods as much. So this is something that you have to decide for yourself. Okay. What about the lap band? The lap band is one of the most one of the surgeries out there that if you actually go out and look at the stats, it has to be like removed or reoperated on more than any other surgery out there. It has the highest rates for that kind of thing. It also has the highest failure rate of any other bariatric surgery. So you're not going to lose enough. I shouldn't say you're not. Most people will not lose as much weight with that as they would with other types of surgery. And there's a good chance that something is going to go wrong with it, to where you're going to have your band removed and a different kind of surgery. It seems like every day on the weight loss surgery groups that I'm in, we have somebody else coming on saying, my band failed, my band slipped, my band is eroding my esophagus. I mean, all these horror stories. And many reputable surgeons in the U.S. are no longer performing the band because it's so problematic. So like I said, I would really research any surgery that you are considering. I know that the band appeals to people because they're like, well, if anything goes wrong, they can take it out. Well, yeah, they can take it out, but that's still surgery to have it taken out. So it's not real easy. I mean, yeah, you can just have the fill for it taken out so that it's not, not preventing you from eating as much, but that's not always the problem. So yeah, so really do your own research. Okay, my experiences with GERD and with gastroesophageal reflux disease, I think. So acid reflux and nausea post-surgery. Nausea I didn't have too much of, with the exception of when I was taking a medication that made it worse for me. Nausea hasn't been terrible. I'm never hungry, but I'm never nauseous either. And never hungry is good for me. So reflux I have had. I had reflux before surgery, and it was actually perfectly treated. I didn't have any symptoms. And post-surgery, it's been horrendous. It's not as horrendous as it was when I started, but it's still pretty bad. I still wake up at night with like rumblings in my esophagus. I'll wake up with a sore throat sometimes from where the acid has made it all the way up there. And it does concern me. I'm on like 80 milligrams of Nexium already, so might try a different proton pump inhibitor, PPI medication, to see if we can get that under better control. But it is a problem. I'm not gonna lie. And some people do recommend, if you're a sleever and you're having excessive reflux issues, sometimes people do consider switching from sleeve to gastric bypass. But I also know some people who've had gastric bypass who have horrible reflux, so that's not always a solution either. It's just something to be aware of, especially if you already have reflux, severe reflux going into this, that you may want to really look hard at the sleeve and make sure that's what you want. Oh, and concerning nausea, acid reflux can actually mimic it can actually make you nauseous, as can dehydration. So if you are nauseous, make sure that both of those issues are taken care of. Make sure that you're taking a PPI. You should always be pretty much always be leaving the hospital post-surgery with an anti-nausea medication and a proton pump inhibitor of some kind. So Nexium, Prilosec, something like that. And dehydration and acid reflux can also mimic hunger. So if you're a recent post-op and you're feeling hunger, check both of those things, because generally that's the problem. Okay, and number 7, here's one that everybody wants to know about: hair loss. Not gonna lie, it's not fun. There's an actual technical term for it that you can Google. It's called telogen effluvium. Such a pretty word for something that's so little fun. Basically, when you're under anesthesia, when you're having a major operation like this, your hair follicles stop growing. And then a few months later, they start shedding the old hair. So, well, I can't say they stop growing. They go dormant. And then a few months later, they start shedding hair. So about 3 months out, 3 to 4 months out is typically when it starts. You start losing some hair. Not everybody does. In some people it happens, but it's not really noticeable. In some people it's hugely noticeable, and my heart goes out to those people. But the good news is it typically only lasts 6 months. And then you'll start seeing little baby hairs growing back, and your hair will start coming back. And it's all because of the shock to your system. I've been fairly lucky. I've been losing some hair in the shower, but so far my hair is still intact. So happy about that, but I am only at about 4 months, so yeah. Let's see. What sort of eating plan do you follow post-leave? This varies entirely on you. I mean, you can work with a dietitian, you can work with your surgeon, however you want to do it. But I personally lose weight better when I'm eating low carb. So I'm eating low carb post-surgery. And many people who have had the sleeve eat about 800 calories a day, sometimes less. I found that in my size, and I am definitely larger than your normal average sleever, that wasn't enough calories for me. My weight stalled for several weeks until I took my calories up to over 1,000 a day. And let me tell you, when your stomach is a half a cup in size, it is hard to take in 1,000 calories a day. I seem to be managing it. My average calories for this week are like 1,050, so very proud of myself for that. The last several weeks I've been able to pretty much keep it up there, except when I was a little sick. So proud of that. So yeah, so your main focus post-op as a sleever is eating a lot of protein. You really want to make sure that you get enough protein in. So it's always protein first. And then if you have any room, you can have vegetables. And then if you have any room after that, you can have a little bit of whatever carb. But primarily you want your focus to be protein. And I'll be honest, I eat very few vegetables right now, with the exception of an avocado for breakfast when I'm feeling like it. I've kind of gotten out of the habit right now. Kind of tired of them. But yeah, you really don't eat a lot of veggies, and if you're eating low carb especially, you really don't eat a lot of fruit. I eat some blueberries from time to time because they're a low carb fruit, and it makes me feel like I'm having something different, but that's about it. Okay, what does the sleeve cost? Again, this is something that's going to vary a lot. First of all, it depends greatly on whether you're in the US or Australia or the UK as to how like the system is set up. In Australia, you can have it done publicly or privately. In order to get it done publicly, there's generally a pretty long wait list, and you generally have to have some other health issues. But you know, anyone can get it done privately if you qualify. And a lot of people do get private health insurance because after you've had it for 12 months, then you qualify and they'll pay most of the cost. The gap generally, I think it ranges anywhere from like what I've seen from about 2,000 to about $5,000, including the anesthetist. I don't know how you say that in Australian. um, Anesthetist, maybe. Um, but yeah, so it can really vary. And then in the States, it depends on your insurance company, what they'll cover, what their requirements are for covering bariatric surgery at all. It's very confusing there as well. But in Australia, you can also use your super to help pay for your surgery if you don't have any other options. Um, what are the best and worst parts of the sleeve? And I should say, this was all prompted by a really sweet person who messaged me on Tumblr today and basically asked me a ton of questions. She's considering surgery, and she was really sweet about it. And I just sort of walked her through my experiences, and I realized I answer these questions kind of all the time. So why don't I just do it in a video all at once, and then I can reach more people that way all at one time. So that's kind of what prompted this. But she did ask what the best and worst parts of having the sleeve were, and I thought that was an excellent question. So let's see. The best part for me has been not being hungry, really, ever. And I know that that won't last forever, but for right now, it's really nice. When they sleeve you, they remove a part of your stomach that's home to most of the production of the hormone that makes you feel hunger. I can't remember if it's leptin that makes you feel hunger and ghrelin that makes you feel satiated, or the other way around, but whichever one of those that makes you feel hunger, most of that is removed. So you're primarily, if you're feeling hungry, you're either dealing with acid reflux mimicking hunger, dehydration mimicking hunger, or you're dealing with head hunger. And you really don't, or like cravings, and that is actually another reason that I eat low carb, because I have far fewer cravings for sweets and carbs when I eat low carb, and I like that. I don't want to be beholden to that. I don't want to be thinking about, how can I find a way to eat chips or cookies or whatever, biscuits, whatever. I much prefer it this way. So, yeah, that for me has been the best part. The worst part has been the reflux. And I'm not going to lie, the pain immediately after surgery was no joke. They very quickly got me into a room and hooked up to a morphine pump that had a button that I could push. But before they had hooked me up to that, before they had, I guess, given me the button for the morphine pump, they were checking on my pain level prior to that. And the nurse kept asking me, is it a 5? And I couldn't talk. Like, my throat was so dry, I couldn't talk. So she was like, is it a 5? And I would say no. And is it a 4? And I would say no. And finally she figured out she needed to go, like, with my husband's help, she figured out she needed to go the other way up. And it was an 8. And if I had never had a kidney stone in my life, it would have been much higher than an 8. Like, that gave me a whole different perspective on pain levels. But this was pretty bad. And if you had asked me immediately in the 24 hours after surgery if I would ever have another surgery again in my life, I would have told you, oh heck no, because the pain was bad. But once they got me hooked up to that morphine button, and I literally just kept knocking myself out. I wanted to sleep. I didn't want to be conscious for any of the pain, so I just kept sleeping. And I think that's one of the best things you can do is sleep. Make sure that your pain is well controlled. Like, don't let them, like, don't just sit there and be brave and ignore your pain. This is the one time in your life that you really want to tell somebody, it hurts. I need more. I need something else. So do that, and make sure that you get up and walk around, because that helps prevent blood clots as soon as you can. and I did it pretty early. And if someone my size can do it, you can too. So anyway, that's all I have for the top 10 questions that pre-apps have. But if you guys have any more questions that you think I can help you with, just throw them in the comments, and I'll try to get to those maybe next time. And again, I'm not a doctor. Like everything that I've said here, I've learned from multiple hours of research on this surgery and reading about other people's experiences. So, and when I say research, I'm not talking just, you know, Googling and looking at like people's opinions. I'm talking about medical journals and reputable hospital websites, things like that. So these aren't just things that I picked up randomly and I'm spouting off without knowing what I'm talking about. So anyway, so I hope this helps somebody, and yeah, leave me some love. Talk to you guys later. Bye.